Hello, I'm Dr. Kang Chung-gyu of K Dental Clinic. I think it seems only yesterday we talked about what is implant, but today we're already covering about suture. Depending on patient conditions, you do implant surgery and then do thorough suturing. That is the key for the success of implant placement. Today, I'm going to talk about what is suturing, what is the clinical significance of that process, what are the instruments you need for suturing, and what are the suturing methods you need for different cases. So this is the content I'm going to cover today. First, I'm going to start with introduction, then look at the instrument and how to do the sutures, and then give you summary. So what is suture? It's to stabilize and to secure tissues in their desired locations, and to position and secure surgical flaps to promote optimal healing. These will be the definitions of suture. Then, what are the clinical results if you do ideal suture? First, very ideal memory suturing would reduce the discomfort of patients. If you have good primary coverage and no wound dehiscence, comfort for patient go down because there will be less pain. With the primary closure, you have less area to be healed, thus accelerating healing speed. And suture with the adequate pressure would stop bleeding, thus reducing discomfort for patient. So this will reduce swelling and pain for patients, in other words. And it will reduce wound dehiscence, thus increase the success rate of the surgery. If you have done GBR, if you have no primary closure and wound dehiscence and then go secondary closure, then in the second surgery, you will see a lot of bone resorption. So when you have performed GBR, you have to do ideal suture so that you can have good primary closure, and that is the way to maximize the effect of bone grafting. Then, what are the basic principles of suture? First is part that needle connects to the silk is called sewage end, and that is the weakest part. So when you grab with needle holder, you should not grab the sewage end, but about 1/4 of the body from the sewage end. If you keep grabbing sewage end, then in the weakest part, the silk might be cut. Second, the needle should always penetrate the tissue at right angles to have more stable suture. Thirdly, suture must move along the curvature of the needle. That is the way to have more stability. Fourth, it's an important one. To prevent tearing of the membrane, the needle must pass through the tissue at a sufficient distance, about 2 or 3 millimeters or more. Fifth, when you open the flap, the suture always needs to perform from the moving tissue to the fixed tissue. If you go in from the fixed side first, you could tear membrane. So always go from the free side and go out through the fixed side. And if possible, sutures need to be performed from thin to the thick tissue. And also, in case of the layered flaps, sutures needs to be done from deep to shallow tissue. Eighth, the depth at which the needle passes through the tissue should be greater than the distance from the incision point for safe suturing. And ninth, this is very important. If you have too tight knot, it could result in necrosis. After suturing, if there's a wide blanching of the site, the blood supply will be prevented, thus leading to necrosis and resulting in wound dehiscence. So tension-free suturing is what you should aim for. 10th, should not be placed on the incision line, because this could prevent healing. 11th, the suture interval should be 3 to 5 millimeters, not too wide apart or not too close together. Then let's look at what are the instruments you use for suturing. First, most important thing would be needle holder. This is something you use very commonly. The most commonly used one would be Hager type, and for ligation, you use Matthew type. And you also have Castrovisual type, which is used for delicate surgery. And of the needle holder, not everything is metal, but you see the golden handle needle holder. It's not to make the needle holder look luxurious. It's the jaw area where you grab the needle. Tungsten carbide has been added to make it stronger. So even if you use for a long time, it will stay sharp, and you can accurately grab it with a persistent and at a certain always consistent strength. And you also have Edison forceps, pincet, also Dean scissor you use for cutting silk. Now, tissue forceps, depending on the tip type, can be as follows. You have commonly used Edison tip and lead tip, which helps you to hold the tissue more stronger, and then you also have Edison Brown tip. And also the grip method, the most commonly used is thumb and third finger grip, most commonly used, as I said. And when you adjust the needle holder grip, you often use this grip. Also, you have palm grip and pen grip, and these are all for precise control. So once you get a lot of experience of suture, then this type of grip can be used for more precise control. Then, now let's look at how you actually do a suture. In suturing, the most important thing will be, as you see, at once, you don't cut through two tissues. You only cut through one tissue, go out again, and then go to another tissue. That would be a better way. This is because if you have a V shape, it's not good. You need to have a U shape. As you can see here, if you go through two tissues at once, then it's a V suture, and there will be introversion of tissue, and the tissues will meet. There could be then wound dehiscence. And to gain the result you want, you go through one tissue again, go out again, and go to another tissue again, so that there will be wide U shape. That is the way for inversion of the tissue, so that the tissues can meet, have the primary closure that you need. So, of course, not all sites need U-shape suture, but if you need a good closure like you have done GBR, then aim for U-shape, suture in 2 steps. Next, let me talk about suture technique. First is interrupted suture and continuous suture. Now, interrupted suture is most commonly used suture method, and it's the most simple and very stable suture. But if you want to upgrade your implant surgery, doing all cases with interrupted suture would not guarantee you good results. So depending on the case, you have to choose the right suturing technique. That is the way to further upgrade your implant skills. Next, we have simple continuous suture. This is continuous interrupted suture, and if the incision line is long, you use this to reduce the suture time. Disadvantage would be a continuous suture, so if there is a loosening in one part, it could impact the whole thing. Next, we have continuous locking suture. Now, this is compared to simple continuous suture, you have lock in the middle, so it doesn't give too much tension on the knot, and in the suture site, adequate level of tension can be maintained. For more detailed technique, I will talk through the offline lectures or in the advanced course. Then, one thing I will talk about what I really wanted to share with you, mattress suture technique. So you have these two photos. On the left, you see two interrupted suture. On the right, you see horizontal mattress suture. And as you see, the left photo, you have two dots connected, but on the right, this suture method, it's you pull the planes. So its mattress suture would be better for primary closure. And not two dots, but as there's four dots, the strength is distributed and it could reduce tearing of soft tissue. And the membrane is upward everted or downward pressed. Hence, you can move the membrane to the direction that you want. So the mattress suture is something that you need to learn. And in terms of horizontal mattress suture, I'm going to first talk about internal mattress suture, and today horizontal internal mattress suture and the hidden X suture and modified low-res suture is what I'm going to cover today. On the left, internal horizontal mattress suture, and right, you have horizontal external mattress suture. So how is it two different? Internal mattress suture, the incision line, the silk that goes, incision line goes to the bottom part. So buccal, lingual to the buccal. When it goes, the silk that goes to incision line goes to the bottom. So the flap is everted. And external mattress suture, on the other hand, the silk that goes through the membrane goes through the top part. So from the buccal, mesial to distal, then again through the incision line from mesial to the other direction. It goes through the top part of the membrane, so it presses that part. So internal mattress suture has the everting effect, whereas external mattress suture has the pressing effect. First, let's look at the horizontal internal mattress suture. As I told you before, it's for the everting effect, and as you can see, on the buccal side, goes in, goes out, on the lingual, goes into lingual again, and goes out buccal again. So the horizontal internal mattress suture is that way, and it has the everting effect, and it allows connective tissues to meet, accelerating the healing, increases the contact area. And for effective suturing, number 2 and 3 distance needs to be about 3 to 5 millimeters so that the planes or sides can meet. And for the everting effect, the indenting point must be more than 5 millimeter away from the incision line. This is to ensure everting effect. And this is a clinical photo. First, you have the interest suture, and in the important part where you have done GBR, horizontal internal mattress suture is done, so the tissue is everted, and to help primary closure. So you go in buccal, goes out lingual, and then lingual go in again and goes out to the buccal again. And this, after this suturing, it cannot be moved. Hence, it's important that if the knot is formed on the lingual side, it's difficult to move tongue. So for the knot to be located on the buccal side, you always have to start from the buccal side. That is one tip you need to remember. Now, after doing GBR, to fix the membrane, you perform Dr. Boozer suture. So as you can see, after applying membrane, first on the lingual or palatal side, you go in through periosteum, you go out lingual palatal side, and that is Dr. Boozer's suture, and it's a periosteal suturing to put the membrane in position. So it's inevitably knot is on the lingual side, and this suture is the horizontal mattress suture. And it's to stabilize membrane. And for that, you perform this suturing technique. Next suturing technique is hidden X suture. As you can see, first, on the major buccal side, you go in, and you go out distal lingual side, and again, distal buccal, you go in, and mesiolingual, you go out. And if you do this suturing from the outside, you see two parallel lines, but on the inside, you see X-shaped form. So this type of suture, you mostly use for ridge preservation, or after doing open membrane technique, you use this to stabilize membrane. Advantages is that because it's X-shaped graft material, you can prevent loss of that. And buccal lingual, the strength is not too strong, so it can keep keratinized tissue in position. Now let's look at a clinical case. It's after extraction, we immediately placed implant, and on the buccal side, there was bone defect. On the lingual side, there was also insufficient bone, so we did bone grafting, and then what I did is for open membrane technique, unobservable cytoplast was applied. After that, hidden X suture was done. So from mesial-distal side, interrupt suture was performed. Then the center where there is membrane, the hidden X suture was done. So mesial-buccal side, you go in, and on the top part of the membrane, and distal palatal, you go out, and on the distal buccal, you go in, and mesial palatal side, you go out. And you see two lines on the outside, and it's stabilized membrane in position with the X shape. And then after 3 weeks, cytoplast was removed, and then you see very cleanly healed. And then the second surgery, you see the bone grafting has been very successful. And you dress, and then you check that the GBR you wanted has been performed. Next suture I want to talk about is modified Laurel suture or horizontal sling mattress suture. This suture is something that I use very often when I perform GBR. As you may well, if you do horizontal internal mattress suture, the side or planes connect together, but the incision line sometimes open up. So you have to do interrupted simple suture also. But this can be inconvenient. So you put two together for the modified Laurel suture. You mostly do this when you have done GBR. It creates everting flap and has less of the flap tearing, and the graft material can be stabilized using this technique. But what you have to be careful is the suture is made X and it's finished by pulling it to the buccal side so that it does not rest on the incision line. I think the video will be helpful. So from the buccal to the lingual, and then from the lingual you go in again and again go out through the buccal side. If you suture here, horizontal internal matrix suture will be what you have done. But here again, you do a knot and the needle from inside to the outside, it goes out. So this suture is the modified Laurel suture. You lock it and create good knot. And from the other side, knot, and also again other side. So 3 knots is what I prefer. And this is the modified Laurel suture technique. So this is clinical photo. As I just told you, on the left, you have done horizontal internal matrix suture. Then to close the line, interrupt suture was done. On the right side, it's the modified Laurel suture that I talked about. So it's more convenient because you put 2 sutures together in 1 suture technique. The clinical set photo, we extracted number 25 due to periodontitis, and after 6 months, came in for implant placement. After placing implant, there was a bone defect, so on the buccolingual side, you see a lot of gap. So first, using Sure Os GBR was performed, covered the membrane, and modified Laurel suture on the important center part was performed. So we tucked on the buccal side. After 3 months, healed, and again did the second surgery, and this is during second surgery, adequate GBR, and through suturing we were able to create bones that we needed and deliver the healing abutment, and second surgery was performed. So as you can see, adequate GBR, adequate suture helped us to maximize the benefits of GBR. Next, I'm going to talk about of the matrix suture, horizontal, external matrix suture, and crisscross suture. Now, crisscross suture, as you can see, it's one of the external matrix suture, and from the buccal to the medial side goes in and goes out to the distal side, and again on the lingual side going distal and goes out distal. So the silk goes through the outer line and presses the flap. And this suture is mostly used in doing CLP or after the Palachi incision to fix it in position. So the advantage is it perfectly presses the valve on the X-shaped area. So again, photo, as you see, after placing implant, healing abutment delivered, and on the posterior, upper posterior, if you have thick flap, then you cannot close it sufficiently. So if you have attached gingiva through Palachi, you push it to the medial side, and to fix the flap in position, you need external matrix suture. So you perform crisscross suture. So medial buccal, distal buccal, and medial palatal, and distal palatal, it goes out, and there's X shape, and you have the Palachi flap that is now pressed and in position. And this was done through the crisscross technique. So for successful suture, let me share with you some tips. First, of course, you need to use good instruments and good suture materials. And you need to grab the needle in the right direction that is suitable to the case. And do good suture and locks and knots, the thread needs to be close to orally, and it's better to hold it with your thumb and index finger. So rather than being a bit distant, be close to the mouth and knot it in the right way. That would be the better way. And if possible, the remaining thread needs to be short as possible. And in making knot, you tie it 3 times, and that is called modified surgeon's knot. First twice the clockwise and one anti-clockwise, and then again clockwise. First knot, it needs to be tucked in the direction where the needle went in, and tucked. I usually tuck it on the buccal side and fix it in place. And the last knot needs to be very strong, so that it would put everything in place and position. And for good suture, again, close to the mouth, your finger goes in, and with one finger you hold the needle, and with the other finger you hold the silk to tug and pull, and that is the tip for good suture. Now, this lecture was about suturing. So you always have beginning and end in everything. In implant also, if you placed implant, then you need to close it successfully with good suture. I hope this lecture has given you information about how to do those suture so that you can have successful implants. Thank you very much.
고맙습니다.